Yes. Good evening, everyone. On behalf of organizing team PG Psychiatry Lecture Series from D.Y. Patil Medical College, Navi Mumbai, I warmly welcome all respected faculty members and participants today for the today's online lecture. It's my privilege to introduce our esteemed chairperson for the day, Dr. Rajesh Maniyar sir, founder director of GIPS Hospital, Ahmedabad, ex-professor of psychiatry, NHL MMC Hospital, Ahmedabad. Sir, thank you for taking out your time and consenting for the chairing the today's session. With this, I would request you to take over the further proceedings. Over to you, sir.
Thank you very much. Thanks to the second department of DY Patil Medical College and special thanks to my friend Dr. Rasmin Cholera. As you know, the subject of today, ECT, an update. ECT itself is a very old treatment, one of the oldest treatment started in 1938. Before even a single psychiatric drug was available. The first psychiatric drug, chlorpromazine, was available in 50s, and this is older than this. Still, it is one of the most effective and robust treatment. ECT has seen so many changes. In my early days of residency, I had given direct ECT also. Then came the ECT based anesthesia. Initially, am I audible?
Yes, sir. Yes, sir.
Excuse me, am I audible?
Yes, sir. Yes, sir. You are.
Okay. Then anesthesia started the initially sine wave ECT, then beep pulse, ultra beep pulse, and then now EEG monitoring and so many other things. Different new neuromodulatory treatment in psychiatry has been started, like TDCS, RTMS, ketamine therapy, and all that. But still, ECT is the best for particular indication. There are a number of misbeliefs or misunderstanding, not only with general public, but also with psychiatrists too. ECT is not the last resort, but it is first resort in certain selected illnesses. It is one of the very safe procedure. Today, we have an authority, Dr. Jagdish Thirthalli, who is working in one of the most important institute of India, NIMHAS, as a professor. May I have his biodata on the screen? Dr. Jagdish Thirthalli's biodata, please. Hello. Yeah. He's a professor and head, Department of Psychiatry in NIMHANS at Bangalore. He has completed his MBBS from Mysore Medical College. And then since then he is working in NIMHANS as assistant professor, associate professor, and then professor. He has fellowship of National Academy of Medical Science in the year 2021. He has so many awards. I'm not reading all the awards because it will take another 1 hour for reading his awards. Over to Dr. Jagdishan. Please let us know about what are the new things in ECT. Over to Dr. Jagdishan.
Thank you, sir. Can I share my, just one moment. I will try to share my, is my screen visible?
Yes, sir.
Yeah.
Yeah.
Yes, sir.
Thank you very much, Chairperson, sir, and the organizer for giving me this opportunity. I was not very familiar with this series of lectures, but when I went through it, it was very impressive the way you have been doing this for so many years without a break, and I think you have generated a wonderful resource of resource material for all the students to see, and also even if, professionals, experienced professionals like me. I think thank you for taking that this very interesting and very useful initiative of having this lecture series. Very interesting topics have been covered. I hope today's topic would be of much interest to particularly students and also practitioners. So I want to say that today's uh, presentation will be mostly focused on clinical aspects, and I'm not going to speak too much on biological aspects of ECT. I'll focus mostly on newer developments of in ECT for depression, because depression is very well established indication for ECT. Though ECT has been used in schizophrenia for many years, and ECT was perhaps used in the first patient with schizophrenia, the literature on schizophrenia is very sparse, and there have been some developments of late, particularly from Indian centers. I will be focusing a few aspects of use of ECT in schizophrenia, and I will delve somewhat on newer developments in the area of cognitive adverse effects of ECT. Now, coming to ECT in depression, as I said, there is robust evidence for depression. For no other indication is the evidence so robust as for depression. Way back in 2003, a meta-analysis which was published in the Lancet clearly said ECT is an effective short-term treatment for depression and is probably more effective than drug therapy. So that after that, there have been no more large-scale sham controlled treatments, trials for the use of ECT in depression. Though this meta-analysis said that ECT is very useful in depression, I would consider that the best evidence for ECT in depression has come from this particular trial, which was published in Orchestra General Psychiatry in 2000. The reason why I'm saying this is the best evidence is because many critics of ECT have raised questions about methodology of establishing the efficacy of depression, ECT in depression, because they said that there are very few sham controlled trials. Unless you have a placebo controlled trial, the evidence is not to be taken very seriously. Of course, there have been sham controlled trials also for depression. But the critics went one step ahead and said that when a patient receives sham ECT versus true ECT, it is very easy for the person to say whether he received sham ECT or true ECT. And also, even the raters who have to rate them in a blinded fashion will be able to say whether this patient received sham ECT or true ECT. They criticized many of the previous trials on that basis. What happened in this particular study is that there was no placebo arm in this. There was low intensity right unilateral ECT, high intensity right unilateral ECT, low intensity bilateral ECT, and high intensity bilateral ECT. There were 4 arms. What its study showed is that the high intensity unilateral and bilateral ECTs were clearly superior to the low intensity right unilateral ECT. Now, if nobody can question this trial, saying that there was no good placebo. Here we can say that the low intensity right unilateral ECT serves as a placebo, and no patient can make out whether he received right unilateral or bilateral or low intensity or high intensity. So this particular study has kind of killed any argument of saying that sham control trials were not good enough. So here a true ECT served as a placebo, and the high intensity right unilateral ECT and bilateral ECTs could clearly show that they were effective. Hence, this is one of the best evidence for the use of ECT in depression. So nearly all guidelines recommend the use of ECT in depression. There are only minor differences about when it should be used. What is new in ECT for depression is ultra brief ECT and some discussion about whether ECT and ketamine can be compared for depression, whether ketamine plus ECT has any benefit in depression, how does ECT fare against magnetic seizure therapy, and there is some newer development called the FEAST, focal electrically administered seizure therapy. I'll briefly cover these things in terms of depression. Now, coming to ultra brief ECT, for the sake of postgraduates, a typical ECT stimulus will look like this. These rectangles represent pulses of electricity. The horizontal lines are pulse widths. The length of the height of the rectangle represents current in milliamperes. The current flows in two directions, positive and negative. A pair of these two pulses is called a cycle, and the entire series of pulses is called a train. Having known this, let us understand what is ultra brief pulse ECT. Now, if you look at these pulses, what is required to elicit a neuronal excitability is a pulse of about 0.3 milliseconds. Typically, brief pulse ECT is about 1 millisecond or up to 1.5 milliseconds. As I said, 0.3 milliseconds is enough. So to give wider pulses, we may be using it beyond its use. Okay. So why not use only 0.3 milliseconds, which is enough for stimulating nerve cells. So that was the logic behind introduction of ultra brief pulse ECT. Many studies have been done to compare ultra brief ECT with brief pulse ECT. About 6 studies were reviewed in 2015. After that, there have been no more comparisons of this nature. What this review clearly showed was that the efficacy was better with brief pulse ECT in terms of depression scores. But you can see that the benefit of brief pulse ECT over ultra brief ECT is fairly small. It may not be clinically relevant. Remission rates were higher in brief pulse ECT, about 1.4 times better than ultra brief ECT. This may be useful for clinicians. Those who received brief pulse ECT recovered by about 1 session less than those who received ultra brief ECT. In practice, it makes a big difference. Even 1 session extra will be that many days of inpatient care, that much of investment in terms of human resource, money, and delay in recovery, etc. So it appears that ultra brief ECT, even at when given at high dose, is slightly inferior in terms of its efficacy. However, its advantage is very clear in terms of cognitive effects. Across so many cognitive domains, including global assessment, retrograde memory, anterograde memory, and other cognitive domains, ultra brief ECT has a clear advantage over brief pulse ECT. So, ultra brief ECT saves short-term cognitive deficits at the cost of efficacy. It may be preferred in those who are concerned about cognitive deficits and in whom urgent rapid recovery may not be the most important focus. We should think of a few other considerations while using ultra brief ECT. One surprising finding was that if ultra brief ECT was used in bilateral ECT, then it was associated with an unusually low response rate of about 35%. Most of the ECT trials show that the response rate of ECT in depression is about 60 to 70%. In this trial, bilateral ECT with ultrabrief ECT returned with very low response rate. It is understood that a complex interplay of electrical parameters on the size and location of neurons may explain this loss of efficacy. Why is this important? It is important because about 50 to 60% of patients who receive ECT do so for indications other than depression, particularly in Asia and India. And unilateral ECT is not well studied in these indications, like schizophrenia, mania, catatonia, etc. Unilateral ECT has been extensively studied in depression, but not in any other indications. Hence, most clinicians tend to use bilateral ECT. Now, ultra brief pulse ECT with a bilateral electrode placement seems to be inferior in efficacy, and it is of concern because of this in our settings. So, in summary, ultra brief ECT has excellent cognition sparing effect both in short and long term. There is slight reduction in efficacy with high dose unilateral ECT in depression, but substantial reduction of efficacy when it comes to bilateral ECT in depression, possibly in other indications also, which has not been well studied. So that's about ultra brief ECT. Let us see how ECT compares with ketamine for depression. Ketamine is becoming very popular. Several routes of administration, IV, IM, intranasal, oral, subcutaneous, you name the route of administration, ketamine can be used in that route. It has very fast anti-suicidal effect. The question is, can it replace ECT? Let us look at the evidence for this. There have been many direct comparisons of patients who were otherwise referred for ECT. In all these trials, patients were referred for ECT and they were randomized to receive either ECT or ketamine. No, these are the studies. Okay. In the first few studies, ECT and ketamine were equal. And in one of the studies, ketamine was found to act faster. In two studies, one of which was done in NIMHANS, Sharma et al., our study, we found ECT to be more rapid and better than ketamine. And one large study of about 186 patients found that ECT is better than ketamine in remission rates. What we should know here is that whether patients had treatment-resistant depression was not clearly indicated in many of the trials, except this Anand et al. Study. Though the author's name looks Indian, this study was done in the US, particularly in the Harvard Medical School. Only this study included patients with treatment-resistant depression. But you can also note that this study was the only study which included outpatients who received ECT. I will go into more details about this particular aspect in this. Whether patients had psychotic symptoms, only these two studies which showed that ECT is more rapid and better than ketamine had some patients who had psychotic symptoms. As you can see, these were the two very large ECT studies, RCTs, which included 186 and 365 patients each. Now, looking at quality of RCTs, you can see that the NIMAN study had the least risk of bias. Okay, accepting the fact that participants were not blinded, which is not possible if you do a study comparing ketamine versus ECT. Across all other domains, our study has been rated to have least risk for bias. And though there is blinding was not done in many of the cases, there is reason to believe that this lack of blinding was not responsible for any bias, because many people who took part in these studies had equal expectation from both ketamine and ECT. Hence, I don't think lack of informant blinding or the participant blinding was an important issue. Though there have been six original studies, there have been more than six meta-analyses, which included these six studies. I have not included all of them. I have included the four of them. As you can see in these meta-analyses, which compared ECT versus ketamine, wherever they had, they included this Anand et al. Study, ECT was either equal to ketamine or better than, ketamine was equal to ECT or better. Wherever this study was left out, we found that ECT is better than ketamine. So this particular study, Anand et al., made a big change. If you did not include this in any meta-analysis, you will end up thinking that ECT is better than ketamine, particularly among inpatients. Whereas in this study, in this meta-analysis, where it included Anand et al. Study, ECT was found to be equivalent to ketamine. So across all studies, adverse effects were consistent. Headache, muscle pain, and cognitive complaints were higher with ECT. Dissociative experience, giddiness, and vertigo were common with ketamine. I said Anand et al. Study made a major change. It has a major impact on to know whether ECT is better than ketamine or not. It is, of course, the largest study. It included patients with treatment-resistant depression, failure of at least 2 antidepressants. It was a non-inferiority study which showed that ketamine is not inferior to ECT, but in fact, ketamine was found actually superior to ECT. But we should pay attention to very unusual characteristics of this particular study. Nearly 90% were outpatients, and the response and remission rates with ECT were very low, 40% and 20%. This is very unusual, as I said earlier also, for any ECT study to come up with very low response and remission rates. There was something very unusual about the ECT part of this particular study. Of course, 90% were outpatients. They had failed only 2 antidepressants, most of them. And the number of antidepressant failures were not provided in detail. So we don't know how many were ultra kind of resistant patients who actually typically receive ECTs. So it may not be, the participants who took part in this study may not have been representative of typical ECT patients. I'll tell you why. All RCTs included consenting patients. While it is ethically sound, many patients who receive ECT do so with 100% support. In other words, somebody else makes a decision for this person to receive ECT. For example, depression with severe psychomotor retardation, agitation, depression with catatonia, psychotic depression, refusal of fluids and medication, particularly the elderly. You should know that most of these patients are not represented in many of these trials, particularly the trial which showed ECT to be inferior to ketamine. So if we refer such cases for ketamine versus ECT, how ketamine may compare with ECT is anybody's guess. So my take is that ketamine seems to be equivalent to ECT in relatively less severely ill non-psychotic patients with depression. For severely ill patients, ECT may be better. But one advantage of ketamine is that it is fairly rapid in terms of managing suicidality of patients, particularly those who have unipolar depression, not so much of bipolar depression. And we should weigh the cognitive versus dissociative adverse effects of both of these treatments. So that is about ECT versus ketamine. Now we will see whether ECT can be given with ketamine, not as treatment but as an anesthetic agent. So ECT, ketamine has been used for anesthesia during ECT. It can be used alone or along with others, particularly propofol called as ketofol. The advantage is that it is useful in cases where seizure elicitation is hard. Ketofol or ketamine given alone helps in elicitation of seizure in elderly patients who may be taking anticonvulsants, etc., where seizure elicitation is difficult. Ketamine anesthesia is better. But the problem is that there is a disadvantage in terms of the side effect of hypertension that can be uncontrolled. Raising blood pressure can happen during ECT. Let's see whether adding ketamine as an anesthetic drug during ECT have an advantage. There have been many studies which have looked into it. In fact, 17 RCTs have been done using ketamine versus other agents for ECT. 12 of these were high quality studies and they included nearly 1,200 participants. So what this meta-analysis showed is that those receiving ketamine plus ECT experienced higher remission than those who received a comparison anesthetic agent. Only 3 studies compared ketamine alone versus ketamine plus other anesthetic agent, but I think we can still take the result as favoring ketamine plus ECT versus other anesthetic agents plus ECT. Other 6 used ketamine with another anesthetic agent. No separate meta-analysis were done of ketamine alone versus other agents. And the ketamine group had a significant advantage by the third. Okay. But only very few trials included patients with treatment-resistant depression. So we don't know whether this combination helps in treatment-resistant depression versus non-treatment-resistant depression. The adverse effects of ketamine group, adverse effect was that ketamine group had higher fear of hallucinations, hypertension, delirium, etc. One thing we should actually notice is that other meta-analysis who have compared ketamine versus other anesthetic agents have reported no significant difference between ketamine and other agents. Hence, it appears that ketamine using ketamine as an anesthetic agent has an advantage, but the evidence is slightly inconsistent. It comes with the cost of adverse effects, particularly of hypertension, some unpleasant experience by patients is dissociative experiences are commoner. It is also unclear if ketamine alone is beneficial, whether it is beneficial when it is tagged with another anesthetic agent. So clinicians should weigh pros and cons and then decide whether they should go for ketamine plus ECT. How does ECT compare with RTMS? Many people have started believing that RTMS can replace ECT for at least depression. But you should know that it is very difficult to compare ECT in general and TMS in general because these are not monolithic treatments. What I mean is ECT can vary in its effects and adverse effects depending on electrode placement, stimulus strength relative to seizure threshold, frequency of sessions, and without medications. TMS also has several parameters to consider. Conventional or patterned TMS, superficial or deep TMS, which are the target areas, what is the amplitude of the pulse, what is the frequency of pulse, what are the number of pulses delivered in a particular RCT, frequency of sessions, all these things matter. So it is very hard if people ask you ECT is better or TMS is better. It is very hard because So many parameters are there. It is like saying whether medicines are better for depression. So there are so many antidepressants which are present. Not all are equal. Anyway, 6 RCTs have been meta-analyzed in this particular paper in 2013, and no head-to-head comparison has happened after this. Okay, so it had about 294 participants, and an average of 15 sessions of RTMS was compared with an average of 8 ECT sessions over, I think, equal number of days. What it clearly shows is that ECT is much better. ECT has almost double the remission rate with an NNT of 6, which is fairly good. And the reduction of depressive symptomatology was significantly more pronounced with ECT group. It has a large effect size of about 1 minus 1. That is, ECT is much better than TMS. But as I said, ECT and TMS, there are many nuances we need to think about all these things before we conclude finally on this aspect. So, efficacy of RTMS in depression is unquestioned. There are several studies and meta-analysis which show that RTMS is very useful for depression. But equally unquestionable is the superiority of efficacy of ECT or TMS. And both have their place, and one may not replace the other. The indications are very different. So I don't think, if you ask me in one word, there may be some advantage of ECT, but TMS has other advantages, and the kind of patients that who will receive ECT versus TMS may differ a lot. What about magnetic seizure therapy, where TMS is used to induce seizures? So in one RCT, these were compared head to head, and there was comparable response and remission rates. The number of sessions to reach remission was more in MST. Just like in ultra-brief ECT, MST patients needed more sessions of ECT, about 2 more ECTs, 2 more sessions to reach remission. But MST had very robust cognitive advantage. Time to reorientation, autobiographical memory, subjective adverse effects were all better with MST. So, can MST, which has significantly less cognitive effect, be used more frequently, like daily application? So, we don't give daily ECTs because of fear of cognitive adverse effects. But MST has very good cognitive advantages. Can we use it daily? Can we reduce the number of days of treatment, but not, of course, costs? So that is one question that we don't know, that has to be explored. So MST may replace ECT in case where there is cognition is a concern, but it is hugely expensive. MST device is about anywhere between 2.5 to 3.5 crores, and if there is a damage to it, it will be so expensive to repair it, whereas ECT devices are very sturdy, and even if there is a damage, there is no problem. And longevity of the device, the MST devices are, once they sell the MST device, they start counting the number of days for which it can be used. After some number of sessions, it will stop working. But ECT is forever. So there are some advantages of ECT versus MST. Participants referred for ECT may not be representative of real-life ECT patients who may have catatonic, suicidal, aggressive. So these are typical patients for ECT. Whether MST works in such patients is still not clear. Finally, about another type of ECT, that is FEAST. There are 3 distinct differences between classical ECT and FEAST. The electrode placement is anterior-posterior, that is just above the right eyebrow and just anterior to the vertex. This is how FEAST is administered. The anterior electrode is small, whereas the posterior electrode is large and oblong. And the direction of current is UD direction. It is from this is the cathode, this is the anode. From posterior to anterior, the current flows. There has been only one study which is an open label, non-randomized study, and it showed that there is feast and regular ECT, that is ultra-brief peritoneal arterial ECT, had equal efficacy, and feast had better cognitive effects. So it may be again cognitive sparing, but maybe equivalent to ultra-brief ECT. So there I finish my topic of ECT in depression. I'll try to quickly cover its role in schizophrenia. Why is ECT in schizophrenia is an important topic? It is because probably more patients with schizophrenia receive ECT than those who receive it for depression. What percentage of patients that receive ECT do for schizophrenia? There is an interesting statistic about it. In England, France, etc., whereas these are Western European countries, ECT is seldom given for schizophrenia. Only 5% or 20% of them, of the all ECT patients, receive it for schizophrenia. Whereas in Eastern Europe, it is more frequently given for schizophrenia. In India, about 40% of all ECT patients have schizophrenia. In Thailand, Japan, etc., ECT numbers are very high for persons with schizophrenia. And there are some variations. You can see some high income countries, again, the percentage of patients who receive ECT for schizophrenia is less, whereas slightly low income countries, very high proportion of ECT patients have schizophrenia. So it is highly varied. UK, USA, and some Western European countries it is low. Eastern Europe and most of the Asia and Africa, percentage of ECT patients with schizophrenia is very high. So in most populous regions like in India, China, Japan, etc., nearly half of the patients who receive ECT do for schizophrenia. Hence, probably more number of patients with schizophrenia receive ECT than with depression. Now, let us look at what has happened in terms of research comparing depression versus schizophrenia. We did a bibliographic analysis of published data in way back in 2009. We looked at the publications in PubMed in English language and human subjects published between 1979 and 2009. What we found was very stark. 65% of all the papers, original articles, were on depression. Only about 8.5% were on schizophrenia. So on the one hand, we have a situation where more number of patients with schizophrenia receive ECT, whereas research is highly skewed towards ECT for depression. So it is perhaps because only a small proportion of them they come from LAMI countries, and in general, LAMI countries publish much less than advanced countries. And of course, there are ethical and pragmatic concerns. Poor capacity to consent is more common in schizophrenia as compared to depression. Cooperativeness to go through rigorous research assessment is also common, is possible in depression, not so much in schizophrenia. So, though most guidelines and systematic review comment that thousands of schizophrenia patients continue to receive ECT with very few attempts to optimize the treatment, the research in schizophrenia and ECT has been very low. So, in 2005, a Cochrane review came, which compared, which systematically reviewed and meta-analyzed RCTs for schizophrenia. So they had many inclusion and exclusion criteria how to select these studies into the RCT. What this meta-analysis showed as a result is that ECT is better than sham ECT or placebo in the short term. Like if ECT is given for schizophrenia, true ECT versus sham ECT, true ECT is better. These are studies where no antipsychotics were given. Only true ECT versus sham ECT. True ECT is better. But if one arm receives antipsychotics and the other arm receives ECT, then antipsychotics are clearly better. So ECT cannot compare with antipsychotics for schizophrenia. They also found that ECT combined with treatment with antipsychotics may be considered as an option, particularly when rapid global improvement and reduction of symptoms is desired. They also concluded that this is also the case for those with schizophrenia who show limited response to medication alone. So they said that if rapid response is required or if there is treatment resistant schizophrenia, ECT may be considered. They also cautioned that these data are so limited that they should only be considered as hypothesis generating. This review did not say that ECT is helpful in expediting the recovery, nor did it say that it is useful for treatment resistant schizophrenia. It only said that these findings lead to a hypothesis that ECT may be better than sham ECT for these indications. They also say that they do suggest a role for addition of ECT for people who show limited response, but this needs further evaluation. So we did that further evaluation in a recent meta-analysis. Makarand and Srinivas, my colleagues and others, were involved in this meta-analysis. We meta-analyzed 12 RCTs where we compared between ECT plus antipsychotics and compared them against antipsychotics alone. We found significant difference in weeks 1, 2, and 4. Okay. The green line shows antipsychotics alone and the red line shows antipsychotic plus ECT in terms of difference from baseline to different weeks of assessment. Clearly, when ECT is compared, ECT plus antipsychotics are compared to antipsychotics alone, ECT seems to expedite the recovery. What the Cochrane review kind of tentatively concluded, we have been able to give a little more confident conclusion that the ECT seems to expedite the recovery when added to antipsychotics. One of my students did her MD thesis also and showed that here in these graphs, the x-axis is number of days after admission, the y-axis is number of inpatient days, number of days after admission when ECT was started. Okay, what you can see is that the earlier the ECT was started, the earlier they were discharged. Okay, this was true of schizophrenia, depression, and mania. There was a direct correlation between how early ECT was introduced and how early the patient was discharged. There is an indirect suggestion that ECT expedites recovery. In schizophrenia also and other indications as well. What about ECT in treatment-resistant schizophrenia? About a third of patients with schizophrenia have treatment-resistant schizophrenia and about half of them do not respond to clozapine. And there is hardly any evidence-based treatment for those who are clozapine resistant. Most guidelines suggest ECT in clozapine-resistant schizophrenia as an option. But what is the evidence for this? What is the evidence for ECT in treatment-resistant schizophrenia? A very scathing attack of use of ECT in treatment-resistant schizophrenia has come from none other than the Royal College of Psychiatrists. It said claims for the efficacy of ECT in treatment-resistant schizophrenia would perhaps best be described as a triumph of anecdote over empiricism. They clearly said that there is no evidence to say that ECT works in treatment-resistant schizophrenia. An important study came from India, from AIIMS Bhubaneswar. They compared 30 treatment-resistant patients with patients with treatment-resistant schizophrenia and randomized them to receive either clozapine or they continued their antipsychotics and received an acute course of ECT and followed up with maintenance ECT for 24 weeks. Through the 6th to 24th week, across several clinical domains, ECT group had better scores. This is the first ever demonstration of any treatment which has been shown to be better than clozapine for treatment-resistant schizophrenia. So, till this study, if you asked anybody which treatment is better for treatment-resistant schizophrenia, the only answer was clozapine. There was no other antipsychotic or any treatment which was better than clozapine. This was the study which showed that ECT is better than clozapine in treatment-resistant schizophrenia. This study had a few problems which we highlighted in one of the letters to the editor. Participants were not blinded, and the rate of blinding was not objectively tested. So there is a possibility that there is some bias in terms of both participant bias as well as assessor bias are possible in this particular study. There was no allocation concealment reported in this paper. There is a possibility of selection bias. We are not sure. Some patients in ECTR received clozapine also because of one of the rules that they had, that if there was not enough improvement, then the other treatment will be given. So many patients who didn't recover with ECT went on to receive clozapine, but their outcome was assessed as if they received only ECT. There was a large effect size for both clozapine and ECT. It is very hard. If you compare this study, the outcome of this study with any other studies with TRS, you will find that this particular study had significantly large effect size. Many patients with treatment-resistant schizophrenia improved substantially. This is an encouraging result, but needs replication. So I suspect that there may be some methodological explanation for why this study showed that ECT is better than clozapine. Nevertheless, if you look at what we want to know is whether ECT is useful in clozapine-resistant schizophrenia. And in an open-label trial, this American study showed that ECT added to clozapine is much better than clozapine alone, but there was no sham arm. When a sham control trial of ECT was done in clozapine-resistant schizophrenia, this study was from Brazil, there was no difference between sham arm versus true arm in clozapine-resistant schizophrenia. So when an open trial was done, ECT was found to be better. When a sham control trial was done, there was no difference. It is in this context, I believe that there is a clinical equipoise. We don't know whether ECT works for treatment-resistant schizophrenia. And in this background, right now we are conducting a study where we are comparing true ECT versus sham ECT in clozapine-resistant schizophrenia, and we are trying to overcome many of the methodological problems of the previous studies. It will be a strictly triple-blind study. In fact, the rater is blind, participants are blind, even the clinicians are blind, and the statistical analysis will be blind. The recruitment is nearly complete, and we want to look at the study, and soon you can expect some publications from this study. In summary, ECT is superior to sham ECT, but inferior to antipsychotics. ECT added to antipsychotics expedites improvement, and role of ECT in TRS is promising, but it's not very clearly established. Okay, so a substantial proportion of patients with schizophrenia have received ECT because of catatonia, suicidality, refusal of food and medication. It is hard for including such patients in clinical trials. So generalizability of RCTs to clinical situation is doubtful. I think we will continue to use ECT for if patients have catatonia, suicidality, etc., etc. We may not wait for RCT level evidence. My final part will be on cognitive adverse effects. This is one of the most important concerns related to ECT. More clinical research in ECT has focused in reducing adverse effect. You see, most of the clinical research that been done has been done to reduce cognitive effects while keeping the efficacy constant, be it unilateral placement, square wave, ultra brief pulse, twice weekly versus thrice weekly. Most of the ECT research is focusing on cognitive aspects. What are the recent developments in this aspect? This important meta-analysis you should definitely, every postgraduate student should read this. It's a fairly large meta-analysis of what happens to cognitive performance in patients who receive ECT before and after ECT. These are the results. Wherever you see red, it means it is significant. If you see a negative sign, that means ECT caused a cognitive impairment. Positive means after ECT, the cognitive functions improve. Okay. So, as you can see, within 3 days, many are in negative and red. That means ECT causes cognitive impairment within 3 days of their patient receiving the ECT course. But you look at what happens after 15 days. Many of them are positive and in red. That means ECT has caused improvement in cognitive effects even after receiving ECT, and some of this is statistically significant. This is across so many cognitive domains, including the ones which I showed above, and episodic memory, spatial problem solving, executive functioning, etc. ECT has cognitive impairing effect within 3 days, but if you give enough time, cognitive functions improve better than the baseline. And if you give enough time, as was done in the previous meta-analysis which focused on depression, even in schizophrenia, we have found that in about 3 months, the cognitive functions came back to baseline or normal functioning happened in most of the cognitive functions. We have developed a clinical assessment tool to quickly assess cognitive impairment. It is called the before ECT recode. It covers most of the domains which are likely to be affected by ECT. This group of people have actually developed even a briefer clinical assessment tool of cognition, that is ECA. But you should know that it does not cover visual memory, which many patients do compare, and psychomotor speed also it does not cover. It does cover what is called as factual knowledge, which is very unlikely to be affected by ECT. So a couple of important domains it does not cover, and one domain which hardly changes with ECT, it does cover. Autobiographical memory is a very important aspect in ECT. It is because permanent loss of some personal memory is very important. This particular aspect was not covered in the meta-analysis that I showed, but it's of very great importance to many patients. There are many methodological challenges in studying autobiographical memory because there is effect of depression, there is effect of time, and there is lack of validated tools. So it is a very important but very difficult to study area. There was a review which was done just a few months back, which showed that post-ECT patients had larger autobiographical memory loss. But what the study very unfortunately did was, in the abstract, it wrote that studies suggest that ECT causes autobiographical memory loss in patients with depression, The results also suggest that the lost memories are not regained. This is the word, this is the sentence that appears in the abstract of this important publication in the British Journal of Psychiatry. If anybody reads this, it can be very scary for people who have to receive ECT, because it says that there is loss of autobiographical memory and the lost memories are not regained. We had a closer look at this meta-analysis. It has very many methodological problems. The meta-analysis clubbed short-term and long-term effects together, and there is a meta-analysis. No surprise, meta-analysis showed that there is significant loss of memory. If you also closely look at long-term studies, there were only 4 studies. 2 of them showed significant effect of ECT, had healthy controls, not controls with depression, and hence the effect of depression on memory could not be segregated from the effect of depression. Effect of ECT. 2 that had controls with depression did not show significant difference between ECT and controls. So, if you take healthy controls, it shows that those who received ECT had longer lasting autobiographical memory deficits. But when you compare, when the comparison group is ECT, those with depression who did not receive ECT versus those who received ECT, there was no difference. So it appears that some of the autobiographical memory loss that were shown in long term in some of these studies was to do with depression and not so much to do with ECT. And one study that was excluded for lack of raw data recovery, in fact, did not show much difference between the 2 groups. So, these same people who wrote that in the abstract also write that estimation of long-term autobiographical memory loss should be considered as tentative. They also say that future studies should prioritize conducting long-term follow-up assessment of autobiographical memory in ECT patients, control group with depression, similar depression severity. So they are very circumscribed in their discussion in the main paper, but in the abstract they have written that memories are lost and they don't get regain of the memory loss. The evidence for permanent loss of memory hence is very tentative at this stage. I conclude by raising a few concerns about training and accessibility of ECT, which I wrote in one of the editorials in the Indian Journal of Psychological Medicine, for which I received a contribution from Dr. Kellner, who is a very veteran ECT researcher. Here I had raised some concerns about declining trends of ECT access to patients. I had highlighted one case of 63-year-old who have a highly accomplished Indian origin finance professional. He had 2-year history of low mood, anhedonia, agitation, social withdrawal, severe anxiety, panic attacks, delusion of nihilism, persecution, and passive death wishes. He had resigned from his high-paying job and shifted to India. He was diagnosed to have depression, bipolar disorder, schizophrenia by high-profile psychiatrists, including leading academic institutes. He was treated with combinations of antidepressant, antipsychotics, but very little improvement was there. Rather, he worsened. He refused food. There was worsening of agitation. He had severe EPS. He had serotonin syndrome, seizures, severe constipation with clozapine, intestinal obstruction, altered sensorium, aspiration pneumonia, and multiple medical and surgical interventions and ICU stay. No psychiatrist considered ECT for him. He was evaluated by geriatric team in SIMHANS, diagnosed to have depression and suggested ECT straight away. They refused. He experienced further worsening and then agreed, and there was a dramatic improvement after 3 sessions of ECT, and after about 11 sessions, 75% improvement was there. And there was an improvement in cognitive symptoms and had started independent life. Right now, he is again gone back to work and is earning. So, a highly accomplished person flourishing in his profession prematurely resigned from his post, made a major decision to migrate to India, experienced several potentially fatal medical conditions secondary to depression and its treatment, and improved substantially with ECT. Timely use of ECT could have avoided many of these problems. Similar experience has been shared by my friend Dr. Mayur in Australia. I'm not going to the details for lack of time. So, for some reason, there is an underutilization of ECT because of stigma, not only in the media and public, even professionals, including psychiatrists, as our respected chairperson was also pointing out, there is a lot of stigma. Need for anesthesia and cognitive effects are also reasons for underutilization of ECT. Now, legislation has brought in one more problem because of which ECT use has become less. But I want to highlight for the sake of postgraduates that one of the important reasons for underutilization of ECT is poor training during their PG centers. Very few centers train students well in ECT, and we are getting a breed of young psychiatrists with very little confidence and skills regarding ECT. The take-home message from my side is that ECT is becoming safer. It remains an important method for treatment in substantially high proportion of severely ill patients. Cognitive effects are generally reversible, or sometimes they even improve cognitive effects. There are newer tools for rapidly assessing cognitive deficits which are available. Logistic difficulties and lack of training may deny many deserving patients an important clinical tool. Thank you. Over to you, Chairperson.
Thank you, Dr. Thirthalli, for an excellent presentation. And I came to know many things which I was also not knowing. I would like to make some comments that still today we don't know the exact mechanism how ECT works, but it works. And the main thing they say that it's a global neuromodulator. It's a global neuromodulator, and that way it works. You have compared ECT with ketamine, RTMS, MST, FIST. From all this, you can say that ECT is still one of the best treatment. ECT is what you say सब दुखों की एक दवा, जिसको बोलते हैं ना पारस मणि. ECT is helpful in depression. It is helpful in schizophrenia. You have not said anything about mania. We use in mania too, and it is definitely helpful. So ECT is helpful in many illnesses with almost minimal side effects. The still most powerful treatment. It is said that the most powerful treatment or the most new treatment is not always the best. Even the old one may be the best, and that is what said, the old is gold. May I have any question from any of the audience, please?
Or if you can put your questions in the chat box, please.
Yes. Can I take up the question, sir?
Yeah, please, Dr. Thirthalli.
Yes,
You can take up the question.
Yes. Dhritiman Das has, I think he is our student. Level of evidence of ECT in bipolar depression. There have been multiple analysis done on this aspect. It appears that ECT does not differentiate between bipolar depression and unipolar depression. There may be a slight advantage. I think people with bipolar depression slightly respond better to ECT than unipolar depression, but I think the difference is not very stark.
I think there are reports that in bipolar depression it is more effective than unipolar sometimes. The other thing which I would like to comment, many institutes or many psychiatrists have, I would put a word delusion that we should give maximum 6 ECT. It may not be easy. You can, according to the duration of the illness, according to the severity of the illness, one can go for 6, 8, 10, 12. And there is now another thing which we are doing now is about the maintenance ECT. If we can, in depression, if we can take maintenance antidepressant, why not antidepressant ECT also? And now we have good number of patients who are on maintenance ECT. They come every month, take ECT and go back, and they feel much better. And if they don't get the ECT every month, there is mild worsening. So, of course, when I was a student and when I was, my teacher used to say that mostly you should give 6 ECT and then stop it. But nowadays we don't do that. We give up to 6, maybe 8, 10, 12, like that. So what is your opinion, Dr. Thirthalli?
Sure. I mean, there were a couple of slides. If I can again share my slide very briefly.
Pardon?
One moment. I'm trying to share my slide again.
Yeah.
There was one slide on that. For sake of time, I didn't. Just give me one moment. Yes. This is the experience from Australia.
Yeah.
He says, I mean, he gave a couple of examples. 65-year-old lady on maintenance ECT for 7 years. She received ECT for 7 years, once in 6 weeks. They tried to stop ECT. They failed. It failed utterly. She relapsed and attempted suicide, which was nearly fatal. She, I think, fell under a moving truck. And then he was put on back on maintenance ECT, and she's doing well. He has also shared another case where schizophrenia, clozapine resistant, he had stabbed himself in the abdomen and he was on maintenance ECT. Because he had stabbed himself in the abdomen, that had led to a lot of adhesions. And for surgery for adhesions, they stopped ECT. He had a very bad relapse. He had bad catatonia. He almost died. But when he was on such severe condition, he was put back on maintenance ECT and he is doing well. He says there are so many of such cases. He has given one of the most severe cases here. So, you have a point. Many of my patients are doing very well on maintenance ECT. And for them, it is a lifesaver, as I made out in these two examples.
We have another question. Please throw some light on use of ECT in conduct disorder or ASPD.
It's an easy question. There is no evidence for its use in conduct disorder or ASPD. I don't think there have been any trials. And I think there is very little rationale for us to use ECT in conduct disorder and ASPD. We may be desperate because there is no other treatment, but I don't think ECT will help in such conditions. And there have been no studies.
And another question is whether bifrontal ECT is better than bitemporal. Dr. Ranjita, I didn't catch it if it is for depression or schizophrenia or both.
Yes, our study was on schizophrenia, and for schizophrenia, bifrontal was better. And there is evidence elsewhere, meta-analysis, which have shown that bifrontal is equivalent to bitemporal for depression, but bifrontal has slight cognitive advantage compared to bitemporal. The study that I showed was from our center on schizophrenia. Bifrontal was better both in terms of efficacy as well as cognitive effects. But ECT was, for depression, it is equivalent to bitemporal, but has mild cognitive advantage.
One thing I would like to add, Doctor, about the bilateral and unilateral, there are definite advantages of unilateral from the memory point of view, cognitive point of view. But unilateral is comparatively little less effective compared to bilateral. And it is said that in mania, one should not give unilateral. If it is given unilateral on a dominant hemisphere, the chance of worsening may be there. So in particular in mania, one should not go for unilateral, and one should always go for bilateral. Am I right?
Yeah, I don't think we have studies which show what you are saying, but there is enough theoretical reasons why it can happen. So unilateral ECT is an antidepressant, so it has a chance of causing mania, whereas bitemporal or bilateral ECTs do not have any directionality. They work for both mania and depression, and hence they are likely to be helpful in mania.
The Dr. Cholera has asked its role in resistant OCD.
There are many case reports of fairly dramatic improvement of ECT with OCD, but many trials have not been very encouraging. Many patients with OCD have significant depression, because of which they are not amenable for even psychotherapy for OCD, behavioral therapy for OCD. They don't cooperate. In such patients, if such patients are given ECT, it has been seen that both obsessions and depression comes down, but depression may remit, but OCD continues. So I'm a little tentative about how good is ECT for OCD, but in my practice, if people do not respond to anything and the severity is very high, I would declare failure of treatment only if, after I have tried a course of ECT for such patients.
One of the participants has asked its role in severe alcoholic dependence syndrome.
I would say there is no role. I think it has not been tried for sure. There is no evidence base to say that ECT works in alcohol dependence syndrome. What it may work is very resistant delirium tremens. It may help. Chronic and severe delirium tremens, it may work. But for relapse prevention in alcohol dependence syndrome, I don't think ECT has a role.
Yeah, I would like to add, sometimes the alcohol dependence syndrome may be secondary to depression. If it is secondary to depression, the ECT might work in depression and it might help in alcohol dependence also.
Any diagnosis, any condition where depression is comorbid and severe, ECT definitely works.
Yeah.
You are right, sir. You are right.
True. I think now there is no further question. First of all, I would like to thank Dr. Thirthalli for her excellent presentation. I've learned many things from you, including me. After my 50 years of experience, still I'm learning from you people. Thank you, D.Y. Patil, Psychiatry Department, for inviting me to chair this session. Special thanks to Dr. Chorera. Over to D.Y. Patil, Psychiatry Department.
Thank you, sir.
Yes, so what a wonderful session. With this, we come to an end of today's session. A very vast topic, and definitely how the time passed away, we didn't realize. And still, there are many questions which are still unanswered. So, on behalf of organizing team, I extend my sincere thanks to our esteemed chairperson, Dr. Rajesh Maniyar sir, for graciously presiding over the session and guiding us. I also express my heartfelt gratitude to our respected speaker, Dr. Jagadisha Thirthalli sir, from the Premier Institute of Nimhans, Bengaluru, for giving us such an enlightening talk and simplifying all the research and practically giving us tips on what in ECT works and its comparison with the other treatment modalities. My thanks to all participants for their active presence and patient listening, and to all the organizing team members who are working behind the scenes. Last but not the least, for Sun Pharma for their unconditional support and providing this technological support. Thank you. Thank you once. Thank you to all of you. We'll
Thank
see
you.
you
Thank you
soon
all.
with the next
Have a good
topic.
evening.
Thank you. Thank you very much, all of you. Thank you
Thank
so
you
much,
all.
Ketan.
Thank you.
Thank you. Just so all of you know, these lectures are available in the video form and the slide form on the website and on the YouTube page for everybody to see it indefinitely. So please take advantage of that. Thank you very much. Have a great evening ahead.
Thank you, everyone. Thank you.